Hello, everyone. This is Sadhana Alangar, HL7's Director of Education. Welcome to the FHIR 101 for the Policy Community webinar. Viet Nguyen, our Chief Standards Implementation Officer, is here to talk about this topic. Viet, take it away.
Thank you very much, Sadhana. Welcome, everyone, and thank you for taking the time out of your day to listen to this webinar. My hope for all of you is that at the end of this webinar, we'll have advanced your state of the art. So if you've never heard about FHIR, or you've just heard a little bit about FHIR and we're wondering about it, you'll definitely learn something. If you're a policy person and want to know why we're having a webinar on FHIR and wanting you to engage, hopefully you'll be able to understand that as well. And if you're a standards developer, and we have a number of you in the audience, and you wonder about, well, why are we talking about policy in a standards discussion or a standards organization, you'll hopefully get something out of that as well. So we'll be giving you some background about the regulatory landscape. We'll jump into the meat of the presentation around FHIR, and then we'll talk about a couple of scenarios at the end. And then finally, we'll conclude with a few examples of questions that have come out from the implementer community with regard to some of the past regulatory rules that have come out from CMS as examples of the importance of having the policy community engaged in the standards process so that we can help have better communication between the different stakeholders in the community and ultimately create the health ecosystem that we really want for our patients and for our communities. So with that, some of you, maybe this is the first time you've been to an HL7 webinar, may not be very familiar, but just in case there are some of you out there, HL7 is a not-for-profit organization. We're founded in 1987. We're an ANSI accredited standards development organization. So ANSI oversees our processes to make sure that we have good, rigorous processes. And I'm proud to say we just finished a major reaccreditation just at the end of last year with ANSI. And our goal in HL7 is really to provide a comprehensive framework for standards, exchange of data, integration of data, sharing, and retrieval of electronic health information. We have 3 product families. Of course, today we'll be talking about FHIR, but for those of you who have been in the industry for a while, you're probably familiar with our version 2 specification that is in wide implementation. Is, I will say, I think about 30 plus years old, as well as the version 3 standard. And in the US, we often call it the Clinical Document Exchange, or CDA standard. And it's also in wide implementation with millions of records being exchanged every month using that specification. HL7 is a global organization with a global community, and we'll be soon being able to color in Africa as a place where we're starting to incubate new HL7 affiliates within the countries there to help them advance their interoperability, understanding, capability, so that they can then be able to engage with our standards and with our standards community to support their own countries and regions. So I often say, and we often say in HL7 in general, we're really a community. The work is not done by 1 or 2 individuals. It's done by really hundreds or thousands of individuals by this point. And so I'll take a moment to express my appreciation to our corporate members and our individual participants and members who take their time and resources to help further the efforts of HL7 and the standards community. So since this is a basic kind of FHIR 101 kind of course, I asked one of my colleagues, Alex Goss, to help me get a sense of where should we start. And we really agreed that we need to start kind of from the beginning. So what are healthcare data standards, for those of you who are not familiar? So we took this definition from a book around patient safety, and they call it it's the context of healthcare. A data standard encompasses the methods, protocols, terminologies, and specifications for collection, exchange, storage, and retrieval of information. And that could be a wide range of data, from clinical data to medical records to imaging data and others. So a standard really is that range of terminology, concepts, all the way to what we do in FHIR, which is trying to advance standards and interoperability at the workflow level. So I'm a terminologist by training. I'm proud of that, and I've been doing it about 20 years. And one thing we learn in working in terminology is making sure we use our terms accurately. So interoperability has a lot of sub-definitions, much like you see in the dictionary. And so for my own sanity over the course of my career, developed this way of looking at interoperability as this 5-layered stack. And what this stack really helps me to organize my understanding of a project, to look at what are the policy and governance activities, what are the clinical administrative processes that we're trying to support, what are the applications or analytics that go into the patient care, how do we represent that information, exchange it, and what is the underlying infrastructure within an organization and between organizations for us to do that. And as I was thinking about this, I came to the conclusion, really interoperability is a vertical, as well as privacy, security, and safety through the stack, because it is important in every layer, and every layer informs every other layer, because it has to be a coherent and a cohesive stack in order to work effectively. So when I talk about interoperability, I'll be really talking about FHIR as a specification, but really within the context of all these other layers of the stack. There's a huge range of stakeholders when it comes to standards, and I will comfortably say it really is everyone in every realm. We have patients, of course, at the center of that, because we want to care for our patients and make sure that the information is there and available and accurate and timely for their care. We have regulators who work on behalf of the public to identify and promote standards. We have public health. We have the provider organization that uses data for patient care. We have vendors and manufacturers who create technology in order to utilize these standards and put them in the front line in practice. We have payers who finance care, and then we have a range of folks, including research, who utilizes this information to identify risk factors, novel treatments, diagnostics, and things. So in an ideal world, we're all working very coherently and cohesively together, and I'm still very hopeful that ultimately we'll do more and more over time, and FHIR will help us to do that. But if we want to think about how does policy drive standards development and adoption? And there are a number of ways policy can do that. And I've just listed a few here. One, the policy makers and agencies listening to their stakeholders who are identifying needs, areas of friction that they aren't able to get the information they need, or the methods of getting that information is either onerous, expensive, poor quality. And so they take that information and then they start to direct resources to help standards development and funding activities to investigate ways we can improve or develop standards, as well as once standards are in their early phases, all the way to when they get more and more mature, funding adoption, such as pilot activities between implementers to take that standard and to mature the standard and make sure that it can start to work at scale. They also set standards directly. I'm sure most of you are familiar with the HIPAA and HIPAA mandated transactions. And so those transactions identify very specific standards for use for a number of particular healthcare administrative workflows. We also have the Office of the National Coordinator and the Cures Act that oversees health information technology and technology vendors, and also define a set of certification criteria for them to comply if they want to say that they are certified to standards. And we're really pleased that the industry and regulators recognize the value of FHIR and have put that into these Cures Act requirements. But not only do the agencies set standards, they also adopt them as well, whether they be CMS and using the blue button, or in the future maybe other FHIR technologies, as well as FDA and the VA and using them in the EHRs that they purchase for the care of veterans. So there are a number of ways that policymakers drive the development. And so we're going to talk a little bit about that in the scheme of the standards and development implementation kind of life cycle. And really it begins with a need. identified by one organization or a community of organizations. We're very fortunate to have 8 FHIR accelerators that are communities that have come together to evaluate and prioritize and to support the development of standards within the payer-provider exchange community, public health, research, and any number of others. And they come together, they identify some important use cases, they plan, and start to work on the development of the specification of FHIR, trying to understand the workflow, the data requirements, and acknowledging and recognizing that there's legacy data that needs to be supported potentially. But how do we both support the legacy data while still building to a future where the data flows more freely and appropriately, security and privacy always in place for the right entities to care for patients and populations. But along the way, we build reference implementations, we do testing, we use our ANSI process to ballot standards, and ultimately we publish them. And then in my role as implementation officer, and over the next while, we'll be developing artifacts that we can share with the community to help the implementer community to pick up our guides more effectively and learn from the best practices of the industry leaders in implementing FHIR. So I put stars next to just a few of the areas where we really think that the policy and the regulator community could really help to spur the advancement of standards. But we also recognize that standards development is what I'll say is the first few miles of a very long journey. And so our goal is to get these standards out into the global marketplace and to get that feedback to improve them, as well as to get the implementer community to implement them for patient care, because that's ultimately our goal, is to improve patient and population care. So why are policies important to implementers? And here's just a few things. When regulators put out regulatory rules, they often put compliance requirements. So it's important for the implementer community to not only understand those requirements and how they can comply, but also in the phases where they are receiving feedback or can give feedback to regulators, they can give appropriate feedback in case what the regulators propose is too difficult, too onerous, or unclear. So it's important that implementers are part of that process, and the regulators have really implemented that, at least I'll say in the US, through the proposed rule process and the OMB processes for presenting proposed regulations to the community. But once a regulation is finalized and we have what we'll call the final rules, they also often dictate guidelines and the specific standards or recommended standards for implementers. So it's important to be able to understand that that specification or the recommendations, and so that you can implement them in your own organization, so that if you have a certification requirement, you can meet those requirements and avoid penalties on one side, but really implement them effectively for your organization and improving efficiency and patient care. But also technical standards like FHIR also fit in the realm of all the other policy requirements around privacy and security that HIPAA mandates beyond identifying specific data standards. But when it comes to these standards, they often require a certain amount of data governance and maintenance of data. So if any of you might have rules where your state dictates how long you maintain data. If you're a payer, you might have other rules, and then these are then put on top of it. So being able to maintain and manage your data so that you can comply with these rules are really important. And there are other aspects around consent, who gets the data appropriately, how is it done through these different technologies, how it affects your partner relationships with your business associates, how you build your infrastructure so that you can utilize and implement these specifications, how do you train your workforce, and then how do you ultimately use this information to, again, improving your care delivery. So I'm a firm believer that really interoperability has to move from a purely compliance activity to a strategic initiative. And the way I would say that is, if you were someone with the knowledge of the internet today, how would you go back to 2006 in the emergence of Web 2.0 and advise brick and mortar businesses who sell retailers, hotel and travel folks, or banks how could they do things differently so that they could utilize this technology in a strategic way. Healthcare is really going to take advantage of all that was learned from those industries. And we really need to start to think of how we can use data interoperability more strategically. So in the US, CMS and ONC have been fairly active over the last 10 years in helping to initially encourage and then require and further drive the adoption of FHIR from when we started in 2011 with the Fresh Look Task Force and the JSON report recommending the use of open APIs, the creation of the first FHIR accelerator before we had that term with the Argonaut project and the coalition of organizations to take FHIR version 2 and create those profiles that are implemented widely and have been updated following the CMS final rules from 2020 as the R4, the FHIR version 4, that is now in ONC certification. So health IT vendors had a deadline of December 31st of last year to make available FHIR and a number of other related technologies in their software, and then providers will be rolling that out over the course of their refresh. But also recently, we've been hard at work responding to some policy and proposed rules from CMS around burden reduction and prior authorization, and we're anticipating potentially a proposed rule coming out around certification for prior auth. So these are clear-cut examples of how the regulators are driving the adoption of FHIR forward. So let's get to the meat of the presentation, talk a little bit about FHIR. But before we do that, some of you may heard me ask, use the term API and may wonder, what's an API? And I've looked up a whole bunch of different definitions. Most of them are very technical, but for the non-technical community, I'd say an API is a technology way for one system to talk to another system to exchange information to do a task. So if we take the example of travel, in the past, you may have used the travel agent where you've given them your travel dates, where you want to go, where you'd like to stay, and they go out and they search for airline tickets, hotel bookings in their systems, and then they come back and give you options. You'll ultimately book and pay for them, and then you'll get a paper itinerary. Each one of those interactions of requesting a flight or a hotel, we're now using the travel platforms. So those travel platforms use APIs. They take in information, they offer that information to an airline with a request for matching flights for the dates and for the locations of travel. Same with commerce. Everything from looking at what's available to purchase, to putting it in your cart, to paying for it, to getting it shipped and being able to track the package moving through the shipping company. They're all done by APIs. And so it's a rhetorical question, but what's healthcare's API? And really, that API is going to be FHIR. And I've been using the acronym, but just to be clear, it stands for Fast Healthcare Interoperability Resources. And it is really a set of data models we call resources, and a set of operations, which are these APIs, along with some associated technologies that add value to that, I'll say, in order to exchange healthcare data. And the huge value, I think, with FHIR and with the what came out of that Fresh Look Task Force is that it's freely available to the implementer community under Creative Commons. And that has been a huge driver for the adoption of FHIR by the technical community, because they could just pick it up. And there was a lot of technologies that they already understood. The challenges really come not as much, honestly, from the technology, but a lot of the policies, having those developers understand the clinical workflows. But ultimately, the goal will be making data available first for patients so they can be more engaged in their care, and especially for caretakers of those patients who may need to be caring for elderly patients or others, to have data that they need in order to help support the care of their loved one. For organization, there's widespread vendor commitment from the EHR vendors, from cloud vendors, and any number of other technology vendors to support FHIR and to adopt FHIR. And as I mentioned, the implementation of FHIR from a technical standpoint is fairly straightforward. To understand the core FHIR, a seasoned software developer can develop a simple application using FHIR and SMART and CDS hooks within a couple of days with some guidance. But as a clinician, I appreciate that FHIR is going to allow me to have more up-to-date data, as well as more comprehensive data to take care of patients and be able to avoid delays in patient care. And I also want to recognize for those clinicians on the call is that we're going to have a lot more data. That's a good thing and could be a bad thing if we can't prioritize the data and draw knowledge from that data. So when I've been talking to the innovator community, that's one of the things I tell them is start to think about how they can make data more useful to the clinicians so that they're just not inundated with more and more data that they have to track. For implementers, as I mentioned, the tools to get started with FHIR are fairly straightforward. And so they can pick it up and start to understand it pretty quickly because it uses web technologies that come from other industries as well. So to jump into a little bit more about FHIR, it's also often helpful to look at how you might actually use it. And so I often use this scenario because it highlights data. So we have a 55-year-old gentleman with hypertension diabetes. They are seen in after-hours clinic because they've had a sore throat. He's had a sore throat for 3 days with a mild fever and no other symptoms. Is on a couple of medications, no allergies, not a smoker, married, 3 children. They do some vital signs that show a slightly elevated blood pressure, but otherwise normal, has some pus on the tonsils, some enlarged lymph nodes, and they did an office rapid strep that was positive. So the individual was diagnosed with a strep throat and prescribed amoxicillin. Pretty common scenario. Many of you, I hope, are familiar, but haven't experienced it yourself. But the gentleman goes and fills that prescription, then develops a rash. Fortunately, no other symptoms associated with that rash, and then comes back and sees the provider and says, I have a rash after I started this. And so they were evaluated and assessed with a penicillin allergy, and their antibiotic was switched. Well, I highlight here in a few different colors. I apologize if the colors are hard to see, but these are all data elements in a narrative that could be represented as FHIR resources or FHIR data. And what that allows us to do is use those standards to improve the quality of the data that's collected so that when it's exchanged, we maintain what we call semantic interoperability, the understanding of what that data means as you move it from one system to another. So there are a number of essential concepts when it comes to talking about FHIR. I won't dive deeply into any of these right now. It's more for you to have heard them for the first time, because it actually does take a number of times both hearing them and actually using them in order to for the concepts to really sink in. So we'll talk about navigation, versioning, resource profiles, operations, and a number of key technologies. So where do I find this specification? I'm going to caveat everything I'm going to show you for the next 10 minutes that most of the screenshots are for FHIR Release 4. And I'm proud to tell you all that we've actually published version 5. And so if you were to go to hl7.org/FHIR, you would get Release 5. So much of it looks very much the same, but there may be some small nuance changes, but all the concepts are interrelatable. So find the specification on hl7.org/FHIR. So the first thing, and as I already mentioned, the version that you look at really matters. So this happens to be a screenshot of Release 4, but each of the pages within the FHIR specification, as well as implementation guides, has a box. It's often red or yellow. Typically, yellow represents the most recent version. Red means that it's not the most recent version. That allows you to link and see all the previous versions. And for our conversation, at least here in the US, you want to look at version 4.0.1, which is the base FHIR version that's in the ONC's certification requirements. But now that we've published version 5, we've addressed a number of concerns that have been brought up by the community and fixed them. But it's an iterative improvement, but version is a bigger topic. Just be aware of which versions you use so that the versions are correct when you're requesting and receiving information. Every page like this also has a link to what we call the current or the build version. And that's where we are continually improving and updating FHIR and finding errors or corrections or draft language that we're working on. The build version or this current version is the most recent. It's typically built multiple times a day, but it's not the same from version build to version build. So we just warn you that you should use a published version, we say, when you're actually going to build something towards production. We have a number of tabs at the top of the base FHIR page to help you navigate. Of course, they're HTML pages, so it's good to keep a breadcrumb of where you go. But if you start from here, it's really a good place to start. We have this getting started page that kind of helps you to figure out what do you want to read and enter learning about FHIR from, whether you're an executive, a clinician, or a developer. So it gives you some background to orient you on how to approach FHIR. We also have a link to documentation, which really helps to understand more for the developers how we put the specification together and organize the information so that there's consistency in it. And this may look like an HTML, simple HTML page, but there's actually a lot of work behind the scenes by Graham Grieve and the FHIR community on our tooling called the implementation, the IG publisher and the FHIR publisher that puts this all together to make sure that it's all working. So we're going to pause for a second for the first important term that you need to know when you're talking about FHIR, which is resource. So resource is a concept, a thing with a known identity. So I can say this resource, you can find information about it, the specification about it at this URL. It contains a set of structured data, and it has a specific version. In the base FHIR release, which is what we're looking at here, this is the international. So these are the generic resources that are used internationally. And this is what you would see if you clicked on that resource page. And they're organized in this view by those foundation, clinical, and clinical reasoning. And you'll see a list of them. I personally like the alphabetical version because I often know what I'm going to be looking for. So I look at this alphabetical. And when you look at the alphabetical, it's important to note, and you'll see that there are numbers next to each of these resources. And these numbers relate to how mature that resource is. So how well has it been tested, vetted, and implemented to assure that it's complete and implementable and stays consistent. And so if you were to click on any of these numbers, you would get to this page, which is the FHIR maturity model that allows you to see what are the criteria that we use to advance a FHIR resource through its maturity. And once it gets to FMM3 and it's been implemented by at least 3 organizations, you get a pretty good level of confidence that the resource works as intended, and that you could pick it up. And when we get to something normative where we put the N, we then set a very high bar to make any changes that might impact existing implementation. So normative is even a higher criteria for maturity. So the base FHIR resources that I showed you that list are what we'll call the 80%, the kind of FHIR resources that we would use nearly in any situation in healthcare. There are about 157, I think, at last count. And that works, recognizing that FHIR is an international standard. But it's also important to note that depending on what country you're in, what realm, or even what specialty, you may need additional information to go along with a particular FHIR resource. So, for example, in the US, for the FHIR patient resource, in the US, we require the documentation of race and ethnicity. So we create, and it's part of our certification, a set of profiles called the US core profiles, and that's part of ONC certification. And those US core profiles are a set of FHIR profiles that ONC says if you're going to exchange information and certified in the US, that's the profile you use. And if you collected and exchanged patient information, you would include race and ethnicity. There are a lot of profiles because there are a lot of scenarios where you're going to exchange information. And as much as possible, we try to avoid creating new profiles if at all possible. We try to derive our new profiles from things that are already required, like US core. But by using these profiles, we improve on interoperability by further specifying the data that is being requested and exchanged. And those additional data elements, like the race and ethnicity, are what we call extensions. We define these extensions in a programmatic way so that when we go to look up a race or an ethnicity, we can look it up against a table of standard codes for that. And that allows us to reach that semantic interoperability that I was mentioning before, that if I say that I am Asian as my race, I use a code. And so if your system needs to know that I'm Asian or is required by law to collect that information, you've collected it. And we would try to avoid duplicate data collection. So we have a number of extensions, and we're building a whole registry around them so that we can better reuse them for as many multiple purposes as possible. And this is an example of the US core profile that you would see if you went to the US core profile, patient profile page. And this is what we call the structural view of a FHIR resource. And these are the particular extensions. There are also some additional specification information for the developers that you'll learn more if you come take one of our training courses or come to an event we have coming up in May. I'll talk about it a little bit later. So that's how we represent data in FHIR. We represent it in a common way through the FHIR base resource, and then we profile them using extensions when we need to specify them further for a given scenario. But now we have to exchange that data. So we exchange that data through the use of these RESTful APIs. They really define a common set of interactions that one system can use to request and retrieve information, or like in travel, submit information for a particular task and then get returned a set of information. And these are done on these FHIR resources. There are operations that are common to pretty much every resource, like the search function, the GraphQL function, or the validation function. And then depending on specific operations, you might have additional custom to that resource operations. We have particular ones for quality measures, let's say, or other functional things that we do. I put up this slide. This is a very, very high level slide. So if you're an architect, don't get too mad at me. But what I really want to represent here is that what we develop in the FHIR community is really this center box around that specification that defines how you can request and respond to FHIR data. So if I'm searching for a patient, I put in a certain set of parameters for the request to a particular FHIR endpoint, and I get a response. Ideally, it's like plugging in your Ethernet cable for your internet or your 3-prong electrical cable. You know electricity is going to flow. You don't necessarily, as a user, worry so much about how electricity is generated or how it gets to your house, but you want to be confident it does. It's different, though, for the organizations that create and maintain that data. And that might be an EHR or a payer that has a legacy system that they are using to support workflows, patient care, et cetera, et cetera. They often create a FHIR translation service or a facade that to an external client or another server looks like FHIR, but in the background does a number of processing activities to do data mapping and to translate a request in a FHIR format into what a legacy search procedure would be. And so the way FHIR has allowed us to advance is to just all use the same request and response and resources so that when we request data, we know what we're asking for. And when we get data, we can be confident that we're getting what we request because we agree as in two entities communicating or community communicating that we're using FHIR in that communication. The benefit for developers is that the organizations that develop these FHIR endpoints, we call them, can publish their specifications or also publish that they comply with a regulatory requirement for a FHIR implementation guide. So that really helps to improve on that interoperability. At the building block level of FHIR, though, are our core terminologies. Terminologies are like making sure you have the right Lego blocks if you want to build something. Those Lego blocks might be those classic Lego blocks, 2x2s and 4x4s, or they could be potentially those Ninjago or Star Wars or, other kind of Lego blocks. But you know that you can clip them one to another because they all use the same kind of clips. So those terminologies are a way we agree that not only are we going to use FHIR to send and receive data, we're also going to represent the data in common terminologies. And those terminologies, some of you may already be familiar with and have worked with, like SNOMED for conditions, RX norm for drugs, LOINC for lab observations or documents. There are any number of them that we list in our specification, and then we utilize them in our resources and profiles, so that when we say you have a lab observation, you have to use LOINC and have to use a LOINC code. And by using that code, we're improving on the quality of the data and the codification, and ultimately that, again, semantic interoperability of that data. These are a number of the more, they're not free, they're very permissive, I'll say, licensing of the standards, at least for the US. We also use a number of licensed codes like CPT and others, where we receive permission to utilize them in our specification and our testing, but we make it clear that if you use these in production, you have appropriate licenses to use them. We have a number of these FHIR modules that really build upon itself. If you look at the homepage, you'll see that these are kind of the foundational level 1 things that are basic developer things. The policy community, I don't think you'll really have to worry about, nor should you worry too much about level 2, because this is how we build FHIR. But ultimately, where we have these level 3s, how are we representing data from patients to practitioners to payers? We represent these resources here at level 3, and then we get into level 4, which is all the clinical aspects of clinical data exchange, from the clinical things to diagnostics to medications. And one important area in FHIR, and I believe will really be an important future in FHIR, is our ability to use the workflow resources and capabilities within FHIR to do workflow integration. And you may wonder, what do I mean by workflow integration? Imagine if you're going to order a study on someone, you're ordering the study, you're sending it to another entity potentially outside your organization who has to accept that request for service. They have to know the patient, they have to deliver the service, maybe a diagnostic test, an x-ray of some kind. They have to be able to create their report and then send it back to you. Those are all steps in a workflow that ultimately we want to be able to have interoperability around, beyond just having interoperable data. And it's similar to what we do in e-commerce, the ability to go from looking for products to putting them in a cart to paying for them to getting delivered. It's one entire and to a consumer seamless workflow. And then ultimately we get to level 5, which is where I'm very excited. This is where we start to leverage data for things like clinical decision support, quality measures, and more complex use of data for supporting clinicians and for caring for patients. So that was the base FHIR specification. And so what I'm going to pivot to are now these, well, I'll call them kind of allied FHIR technologies. Many of these were developed by the Argonaut group I mentioned before. They, are a lot of the technology folks who are looking for what can we do with FHIR? How can we improve on the specification? One of these is the Smart on FHIR, and this too is also noted in the ONC certification. And the idea here is that you want to be able to create applications that can be web-based, used on a computer, on a mobile device, or embedded within an EHR, and use the authentication that for the individual patient or for the provider to make sure access is appropriate. and then using FHIR APIs, read data from the EHR in order to improve data visualization, clinical decision support, and in the case of burden reduction and prior authorization, lower the burden of data identification, retrieval, and submission in the prior auth process. So Smart on FHIR is an important technology, and I like to say it's our way of getting to EHR 2.0, because the EHR companies have just so much resources to start advancing their EHRs, but there's a whole community of clinicians and others who would like to be able to do things with the data and advance the capabilities of the EHR, and this gives them an opportunity to build their own technologies. And this past week, we were at a conference in Nashville, the Vive conference, and one of the vendors who has been working in the FHIR realm for the past 6 or 7 years now has her company's Smart on FHIR app implemented in 4 different EHRs. So it's really great to see that this Smart on FHIR approach is really working well. Another is CDS hooks. The way to think about CDS hooks is they're hooks into the workflow of the clinician that allows a utilizer, somebody who subscribes to a hook, to be able to gather information at that step, ask for some clinical decision support, and then return that information to the provider in hopefully a very useful way for patient care. This is really the holy grail of being able to do interoperable clinical decision support and intervening in workflow at the right time for the right patient for the right reason with useful information to the provider. And in this example, it's not a great example, it's an okay example, but the provider wants to order a medication, a Toprol XL. And in the background, when they order it, this hook is triggered, and the EHR goes and reaches out to a payer's clinical decision support and service, and the payer reads data from the EHR using FHIR, and then returns one of 3 recommendations. One could just give me some information. This costs $200 a month, and the patient pays $30. Or could provide some guidance. This is a this patient hasn't been tried on a first line antihypertensive. Consider switching to hydrochlorothiazide, and the provider can choose to initiate the switch of their order to this other thing. Or in the case of what we do in burden reduction and prior authorization, provide a link to launch a smart application or functionality within the EHR to gather data for prior authorization. So you can imagine there are any number of places like ordering, opening a chart, reviewing labs, that might be a good place for providing external clinical decision support to the clinician in order to bring awareness to things that are important, or to help guide them on how to use the information that's already available to them. Bulk data access, or FHIR bulk data, is really a very promising area in FHIR. And the idea here is that historically, what we developed in FHIR has been for patient level, one patient at a time, one request at a time. But the reality is, much of what we do in healthcare, we work with lists of patients and do large volumes of data exchange, whether they be quality measures or exchanging immunization data with the public health community. And so the bulk data access specification was put together in order for data requesters to provide a list of patients to an endpoint that supports the bulk data, and be able to retrieve that data once it's all assembled, because we're talking potentially hundreds or thousands of patients. And so this is a great opportunity for when we look at value-based care, or we look at quality measures, or things in public health where we may be exchanging significant amount of data that just isn't feasible to exchange at a real-time API. Clinical quality language is another very important area, and it is a bit of advanced FHIR, but the idea with CQL is the ability to create some scripting, some logic that allows us to identify specific FHIR data, do calculations or things with that data, and then provide reports on that data. We utilize CQL fairly extensively in clinical decision support, as well as in digital quality measures. Some work that's been going on for really years within HL7 with the support of CMS and NCQA and others in the quality community to really advance CQL to the point where we can represent most quality measures that have structured data. So that's a key thing in CQL. And really the goal here is that the measure authorities specify what they want in CQL, and then the providers deliver care as they would normally do, and data that's generated can be identified and retrieved and reported on using our CQL and our FHIR framework, which really holds a lot of promise for saving time and energy for those who have to do a lot of quality measure reporting. So the last kind of major topic we want to talk about is implementation guides. So why do we need implementation guides? We need implementation guides because what we have in FHIR and what I've just shown you are a bunch of, by way of metaphor, ingredients and tools, but without a recipe. And so implementation guides provide a kind of recipe to take FHIR profiles or a workflow and utilize FHIR within that workflow. And by doing that, you identify who's participating in the exchange, and you further specify, clarify how the exchange occurs and what is being requested, what is the response, and your expectations on the behavior of the systems. And that's really key, because if you ever go to like a kid's symphony, they're all reading on the same sheet, but not so well. And then you go to a professional symphony and it's grand and beautiful. And that's because they're all singing from the same, or playing from the same music sheets. But so an implementation guide really takes those things I've mentioned, the profiles that are created to support a particular workflow that supports a set of data requirements, and then using the operations to fit within that workflow in order to support the workflow with interoperability. And the FHIR implementation guides themselves provide a lot of guidance, but just like you can't have one recipe to make a meal, or at least a multi-course meal, often implementation guides are used together. Like a guide might reference that Smart on FHIR, that CDS hooks I mentioned, or might reference that US core. So it's important to know how they work together. They provide examples of the scenarios that the groups that built those guides want to highlight to exemplify how the transactions may occur. They provide all the additional FHIR artifacts that you can use in the implementation actual by developers, and how you would conform and show that you've implemented it in a consistent way within FHIR. These are just a few of the kind of core things that are in the FHIR implementation guides. And over time, we really are trying to standardize the guides more and more so that the implementer community knows what to expect when they pick up a guide. But for the most part, you'll see that there's a lot of commonalities between guides. But these guides will really provide that bridge between the folks who are the business folks who know their workflow and know their organization, who read the narrative parts of the implementation guide, but understand the technical, with the developers and the architects who have to understand the technical aspects and write the code, but they need to understand how it fits into business and clinical workflows. So that the implementation guides provide that bridge. So if you haven't in the past reviewed an implementation guide, we encourage you to. We love to get feedback about our guides during the balloting process, as well as after guides are published, because we're always looking for where are the gaps, what might be errors, or where can we provide more clarification. So when you read it, ask, is this the workflow that they're trying to support? Does that make sense? Does it have all the data that I think I would need if I were to implement this? If you're a technical person, is it implementable? What other technologies do I have to also build in order to support this guide? And then if in the regulatory standpoint, how am I going to demonstrate that I've complied with this guide so that I can say I'm conformant with a particular policy rule? So just a couple of scenarios about guides that are already out there that have been identified in the CMS's Patient Access API final rule, and now the Provider Access API in the recent proposed rule. And this guide really defines the methodology by which payers get clinical information from providers as well as claims information. They take that information and create a FHIR endpoint that either a provider can use or a patient can use in order to get their clinical information, and for a patient, the financial information and claims as well. So this is very high level. At our upcoming event, we'll dig into more of these. But the idea here is that we create that patient access API so that payers can make data available for patients. And we're going to leverage the same specification and take out the financial data to provide this information for providers. And it's really valuable for someone like me who's a primary care provider, because the first time I see a patient, I'm likely to not have enough complete information to get a full picture of their care. And that might ultimately delay care or might lead me to repeat tests that I don't need to repeat. And so by having this clinical information when I see the patient, I'm hopefully going to be able to provide better care, more well-informed care, engage the patient, and make it more timely. We also have this payer data exchange, which we use for payer to payers. So in the rules, we look at how when you move from one payer to another payer, one of covered entities like Medicare Advantage, how do we get that data so that you can choose to have that data move with you? Same FHIR data, different entities, but the idea is that you get to build a collection of information that can move along with you as you move from place to place or payer to payer, so that it's complete and there when it's needed for patient care. So just a few thoughts about why should the policy community understand FHIR. And the way I did this is really, hopefully I've explained a little bit of it, but by way of example. So these Q&As were taken from questions and responses by CMS for the patient access API rule a while back. And so one question really looks at the structured versus unstructured data. So one of the things that the community of implementers asks are, do we have to convert all these large unstructured documents that come in PDFs to FHIR and be able to exchange them? And this was an important question because that might not always be done in a consistent, repeatable way and may potentially cause issues with patient safety. And the response was that they had to be able to meet the technical standards, so making data available via the ONC cures, which is really, for the most part, US core FHIR resources, so that they don't have to create new data. So that's an important concept between structured and unstructured data. Authorization. Like how authorization in the modern era is not done with paper and pen. It's done by login credentials and other things. So this question really goes to, can I get, do I have to accept credentials from another payer when that payer does a payer-to-payer request? So in this case, the response was around, can somebody be authorized to allow for sharing of data, such as from a parent or guardian. So this is where we over time need more and more clarity from the policy community, so that it becomes clear who these entities are, whether they be patient representatives, caregivers, or maybe in the future another entity who might want to utilize the data for, say, life insurance or something else. So authorization is important. What are the compliance requirements? In this question, and specific for patient access API, does CMS require certification? Because certification is even a higher bar for these APIs. And at that time, when this question was asked and responded to, there were no certification requirements, but there were, there were still folks monitoring or receiving responses from the community when individuals couldn't find these APIs that a given payer was supposed to implement. So these are kind of some of the nuances that are important. And this is another really important one. What does maintain data mean? And so this was a really a challenging one, and to add another nuance, maintained by the payer directly or by their business associate. And so being able to understand the question and saying that the maintain is anything that they have access or control or authority over the data is maintained data, which once they write that and give us that feedback, it makes a lot more sense. So it's important for the implementer community to be able to read these rules and know the questions to ask, and for the policy folks to respond. So in the last 2 minutes, I apologize, I won't be able to answer questions because I've run out of time, but we have information at hl7.org to all of our work groups. The events link links you to all of our use cases and our work group calls, use cases of the accelerators. We encourage you to go to Confluence. We have links to all of our work groups, our accelerator programs, our affiliates. There's a wealth of information there if you want to find out more. If you're a developer and technical, we encourage you to join chat.fhir.org. It's free, and you can find, you can ask questions there about FHIR and your implementation. But we really want to give you this webinar as a taste of what's to come in our next Working Group Meeting Plus. So historically, HL7 has had a 3-time-a-year working group meeting where we bring the standards community together. We start off with a connect-a-thon, doing technical work on the weekend before, and then meeting as work groups to really hash through and how to improve our standards. What we have decided to do for May is expand the scope of the working group meeting and try to bring in the implementer community. That's what the plus is. We want to expand the participation by the implementer community by providing more content. And so we have keynote speakers from ONC, CMS, FDA, CDC, NIH, who are coming to, to talk about their interoperability priorities and where they see their vision. And then we'll have presentations from the accelerators, if you want to know more about them in general, or some of the deep dives into their work. We'll have some expanded education and demo sessions. And we really just want to bring the community all together so that we all start to work with each other and learn about the process in general, so that we know how we can best contribute to the improvement of standards and the care of patients. So I'm going to leave this up with a QR code. We'll leave it up for a bit. I apologize again, I'm not able to answer questions. I'm at time. We'll save this recording. We'll take all these questions and we'll try to add them to when we expand this content to the whole first day of the Working Group Meeting Plus. So every topic that I've touched on will have its own extended time at the Working Group meeting. So thank you again for your participation today, for being here with us. And we really hope we can see you at the Working Group meeting in New Orleans. We also have a virtual option for our keynote content for the Working Group meeting. So if you're not able to travel, but still want to hear from the regulatory community and do some of that expanded education, please join us virtually as well. Thank you. Thanks again. Have a great rest of your day.
Thanks a lot, Viet. That was a very good overview of FHIR. Thanks everyone for joining us. We hope to see you in our future events and classes, as Viet said. Till we meet again, bye everyone. This is Sadhana Langar signing off.